Please.
Thank you. So today we would talk about the strategies to improve success in specifically in the subset of patients of PCOS in ART. We are going to have a little bit of boring theories as well coming up, but it is a basis of theory that we can build our practice on because we need to know the physiology. So the first and foremost, what is the fertility treatment for PCOS? We need to know the principles as well. The principle of infertility treatment initially includes preconception guidelines and the use of drugs to induce mono or bifollicular ovulation. That is the primary treatment in terms of PCOS. The use of exogenous gonadotrophins or laparoscopic drilling are considered the second line of treatment, whereas IVF or ART is only the third line of treatment. The choice of an appropriate treatment depends on the patient's age, the presence of other factors which are associated with the diagnosis of infertility, the experience and the duration of previous treatment, and the level of anxiety of the couple. So that is the way in which we have to go through the treatment of PCOS, provided all other things are fine. And done, and the last stage comes around our ART. So what is PCOS? We all know what is PCOS, but just giving you a small, brief recap. It is one of the most widespread endocrine disease occurring in the women of reproductive age group, even up to the tune of 3 to 13%. It is characterized not only by hyperandrogenemia and menstrual disorders. It is commonly associated with infertility, which is most probably due to the absence of ovulation and also as a metabolic syndrome. Little bit going deeper on the epigenetic level, why it happens, there is a theory, is that during the period of embryo-fetal development and infancy and adolescence, the excess androgens leads to the formation of abdominal and visceral obesity, and at the later age, the insulin resistance and hyperinsulinemia, which subsequently closes a vicious circle of insulin resistance. So it is hyperinsulinemia, hyperandrogenism, PCOS, which again comes back to, like, you know, the circle, hyperinsulinism, more hyperandrogenism, and more PCOS. So it's a basic reason is insulin resistance, and that is where it starts. That's a reason theory. Excuse me. And insulin resistance can be found in women with PCOS regardless of body mass index. There are two ways of hyperproduction of androgens or hyperandrogenemia in PCOS. Number one is in the high level of LH, which can be found in patients without obesity, our thin PCOS, but with insulin resistance. The second type of patients are the obese people who will have definitely insulin resistance, but could also have normal levels of LH. The insulin is synergized with LH, stimulating the testosterone synthesis by the theca cells of the ovary. This is a and gonadotrophic effect on the ovary, which increases the LH-induced synthesis and the secretion of androgens by the ovary. So this is how we have hyperandrogenism in PCOS. In addition to hyperinsulinemia, in addition to having hyperandrogenism, hyperinsulinemia also does stimulate the development of andral follicles, which means how it happens, it increases the sensitivity of the granulosa cells to the FSH. Thereby, there are lots of small andral follicles coming up. And this primarily is the reason for the cystic lesions, as we call it, the PCO morphology, and inherently an increase in the ovarian volume. So the importance of insulin resistance in PCOS is indirectly evidenced by the fact that insulin sensitizers have been suggested as the adjuvant or alternative for the treatment of hyperinsulinemia induced ovarian dysfunction. So that's a lot of theory. And what is the crux of diagnosis? All these are the epigenetic and the molecular levels. But how do we diagnose clinically? We all know it already. But just a recap again, there are three factors to be decided on. One is oligo or non-ovulation. The second one is the clinical or biochemical signs of hyperandrogenism. And the third one is the polycystic ovarian morphology on ultrasound. All three may not have to be there, but there has to be at least two of the three to diagnose the patient as a case of polycystic ovarian syndrome. Now, we have diagnosed this patient, and the patient has gone through 6 cycles or cycles of ovulation induction, such as with our retrosol aiming at monofollicular development. However, they have not gone to be pregnant. Then what else to do? Where can we go? And then they've been going through other things, and now they've landed up with ART with you. So when they landed with ART, how can we improve? Where are the avenues that we can improve? The first thing is always pre-treatment to ovarian stimulation. The actual, the crux of the entire thing, ovarian stimulation. And what all do we have to do in the IVF laboratory which can contribute to increasing the success of such patients? Pre-treatment. See, as we know, the theory has been coming around now that the eggs that we see in this cycle was not recruited this cycle. It was probably recruited 2 cycles before. In that way, if we infer that, then the eggs what I see today was recruited 2 months ago, which means I need to pump up whatever I need to do to improve the oocyte quality before I start the ovarian stimulation, at least a month to 2 months, and that is when it is optimal. So, while a high number of oocytes can be obtained in PCOS patients during ART, there are definitely concerns on the quality and maturity of these oocytes. So, and multiple pregnancy and OHSS are the major complications in these patients, and hence we have various measures to reduce all of this, primarily to improve the oocyte quality. The first and foremost in any treatment of PCOS is lifestyle modification. The primary management is lifestyle modification. Even as less a body weight loss of 5 to 10% over, even if it's over a period of 6 months, regardless of the BMI, is associated with improvement in central obesity, hyperandrogenism, and ovulation rate. So the moment there is hyperandrogenism goes down and there is insulin resistance goes down, the milieu of the ovary and hence the quality of the oocyte improves drastically. Obesity has had great impact on reproductive health, such as including ovulation disorders. It decreases pregnancy rate, it increases abortion rate, and definitely it increases the risk of pregnancy complications, including preeclampsia and gestational diabetes. And the entire spectrum is seen, the entire spectrum of complications is well seen in PCOS patients. I'm sure you would have observed that all these things are much more in an uncontrolled PCOS. Even if you have kept them very well under control, it does happen more often than our general population. In ART, the response of obese PCOS patients to assisted pregnancy drug is reduced, and the success rate of assisted pregnancy is also reduced. So how do we do it? In addition to improving the reproductive and the metabolic factors, the reduction in body weight is associated with reduced incidence of complications during pregnancy and also during neonatal period. The risk of preterm, as it has been published in a big paper, for preterm birth and preeclampsia is associated with maternal hyperandrogenism. So the moment we are able to at least help that or reduce that to a bit, it directly implies on the reproductive function and the health of the baby. The International Androgen Excess and PCOS Society has suggested that a physical exercise of more than 150 minutes per week was recommended to maintain a healthy body quality and condition, including at least 90 minutes of moderate high intensity exercise, such as maybe football or basketball, or at least brisk walking and running is the best suited for our women. So what does Cochrane say about this? Cochrane also says that lifestyle intervention may improve the free androgen index, that is FAI, the weight and the BMI, but they are not uncertain about the effect of lifestyle intervention on glucose tolerance. There has been no studies to their evidence level to looking at the effect of lifestyle modification on live birth, miscarriage or menstrual regularities. But some studies in the Cochrane review, which was just published last year, were of low quality mainly due to the high and unclear risk of bias across most domains and high heterogeneity of the free androgen index outcome. The next most common pre-treatment that we have been doing forever, ages ever, is the metformin. Now, there is no evidence of better live birth rate when metformin is used alone or in combination with clomiphene citrate. However, when metformin is used along with gonadotrophins, it happens to double or at least increase the clinical pregnancy rates and the live birth rate. Metformin as an adjuvant in IVF had a better prognosis in OHSs, an increased clinical pregnancy rate, has lesser cancellation rate and a high live birth rate. However, since even though no statistical differences were found in between the gonadotrophin use, this difference in the pregnancy rate when metformin is used as adjuvant, it was not different when there was different amount of gonadotrophins used or the different brands of gonadotrophin used or the duration of, it was irrespective of any of this. That is the type of gonadotrophin, amount of gonadotrophin, duration of gonadotrophin, any of that did not, or the number of oocytes or multiple pregnancy rates did not have any effect on this particular statement that metformin gives us better outcome in terms of when used in IVF. However, routine use of IVF of metformin in cycles of ovarian stimulation for IVF in women with PCOS is not recommended basically because of the gastrointestinal symptoms or side effects as we can call it. So what did Cochrane say? Cochrane has come out with lots of things in the past year or two. It suggested that metformin may be beneficial over placebo for live birth. However, more women experience the GI symptoms. They were uncertain if, again, metformin plus CC improves the live birth rate, but however, gastrointestinal side effects are probably increased with the combined therapy. That is something that we need to have in mind and always tell our patients that yes, you are expected to have this problem of diarrhea, but then the moment you have the diarrhea, don't worry about it. It's a slight amount of loose stools. Don't worry, it is if we counsel them that it is the drug acting, they probably will understand. The results differed. In this particular Cochrane, they were very clear about it that the results differed by the BMI, emphasizing the importance of stratifying results when we use metformin as an adjuvant to be stratified on the basis of BMI. Due to the low quality evidence, they were uncertain about the effect of metformin on miscarriage in all the three comparisons. So this is exactly what they had given. They had 5 trials with a total of 264. There was no increase in the difference in the risk of multiple pregnancy or thing, but they did note a high rate of live birth rate, ongoing pregnancy rate and clinical pregnancy rate with metformin. And that's very important to us, isn't it? The next most common thing that is used now is the myoinositol. It is a supplementation in women with polycystic ovarian syndrome. It has been quite extensively used in the past few years, and there are lots of papers coming out as well. It is a recognized insulin sensitizing activator and has been used to prevent or treat a number of metabolic disorders related to insulin resistance, such as metabolic syndrome, gestational diabetes, and polycystic ovarian syndrome. It is also noteworthy to note that improvement of insulin resistance and reduction of circulating insulin are the key therapeutic targets in PCOS, enhancing the fertility and reducing the lifelong risk for type 2 diabetes and early cardiovascular disease. Besides metformin, myoinositol is now considered as a further insulin sensitizing supplement which could benefit women with PCOS. There were 9 RCTs involving 247 cases and 249 controls were used. They found a significant decrease in the fasting insulin and HOMA index and a slight reduction in the testosterone concentration as well. Hence, it led to the inference that the beneficial effect of MI, that is myoinositol, in improving the metabolic profile of women with PCOS is concomitantly also reducing their hyperandrogenism. As we all know, that the moment there is a reduction in the hyperandrogenism, we seem to have beneficial effects in PCOS. So there was this meta-analysis which concluded that after they reviewed a lot of literature, it is a very recent publication in 2020, they concluded that as an insulin sensitizing agent, myoinositol has a role in improving the quality of embryos in women with PCOS who undergo ART procedures. However, they still wanted a larger study to know how it can improve the oocyte quality and embryo quality as well. And what did the 2000, see this Cochrane came a year ago. After that, they had accumulated some more evidence, but still we will also get to know what Cochrane said. Cochrane said that in light of the available evidence, which was very low quality in 2018, they were uncertain about the role of myoinositol in improving the live birth rate or clinical pregnancy rate in subfertile women with PCOS undergoing IVF and having myoinositol in the pre-treatment as compared to the standard treatment. However, it also decreases the miscarriage rates or multiple pregnancy rates for the same women taking myoinositol compared to standard treatment. So it may not increase, but it may decrease. It may not increase the pregnancy rate, but it may decrease the miscarriage rates and the multiple pregnancy rates. So I guess we will have to have larger studies, or we all have to yet publish whatever data we have on usage of myoinositol to have more clarity on this molecule. Another molecule that has come around recently is the resveratrol. I have not included that as of now because I think it is still very much in the budding stages. We are yet to use it. So only after using it, we might have some experience on it. The second line of treatment that we always think about for women with PCOS is the laparoscopic ovarian drilling. It is only the second line of treatment. And this technique should be used in cases of anovulatory women with only in CC resistant PCOS who probably require laparoscopy for any other reason. So as of now, we don't have a primary indication to go and do a laparoscopic ovarian drilling in women with PCOS who are posted to go for IVF soon. However, there has been observational studies demonstrating that the ovulation rate was between 54 to 76% in 6 months following laparoscopic ovarian drilling and 33 to 88% in 12 months after the procedure. And during this waiting time, spontaneous pregnancy rate ranged between 28 and 56%, and in a year it was about 54 to 70% respectively. However, because of the low quality of evidence that is associated with observational studies, we may not be able to admit this as a very high quality evidence, but it is always good to know the direction in which probably evidence might be coming later on as well. What did the Cochrane say? It came around right now in 2020. Laparoscopic ovarian drilling with or without medical ovulation induction, they said it decreases the live birth rate in women with anovulatory PCOS and CC resistance as compared to medical ovulation alone. It was a moderate quality evidence which showed that laparoscopic ovarian drilling probably also reduces the number of multiple pregnancy rate. It reduces the pregnancy rate, it reduces the multiple pregnancy rates, and there was a low quality evidence which suggested that there may be little or no difference between the treatments for the likelihood of a clinical pregnancy, and there is uncertainty about the effect of LOD compared with ovulation induction alone on miscarriage. However, laparoscopic ovarian drilling reduced to decrease in the OHSS incidence. So we've had a pre-treatment. So before we go for IVF, always we have a period of pre-treatment. That's what we have done. So the effect, the advantages would be to you add metformin or myoinositol. Maybe laparoscopic ovarian drilling is not the key right now, because we do have drugs to reduce the hyperstimulation, OHSS, later on following the stimulation for IVF. However, the crux and the most important thing that we do have to prepare the patients for IVF, and what depends hugely, is the drugs or the controlled ovarian stimulation, as we call it. The basic thing that we have to understand when we start controlled ovarian stimulation for women with PCOS is that they are quite difficult to stimulate in a controlled manner. Whether the intention is to induce either monofollicular or multifollicular, it is quite difficult to stimulate them. They either have very high resistance to stimulation. Even after giving 375 units of FSH for 14 days, you may get nothing. Or you might have to give, they may give an exaggerated response just for 37.5 units of FSH, or just a CC, or sometimes for a even for letrozole, sometimes you want only one, you might see 4, and you wouldn't know what to do. It is, they have a plethora of, they go from both ends, one which is very resistant to stimulation, to the other end where they have an super exacerbated response as well. You have the whole entire spectrum can be seen in PCOS. And they have a very high cancellation rate as well, in the sense the resistance to not having even one single follicle is high in a PCOS than in a normal responder. So the challenges that occur is the diversity of the protocols that are available for IVF. The most important concern in PCOS is the high incidence of ovarian hyperstimulation syndrome, which is again exacerbated by the high estrogen levels that these women have, which leads to accelerated endometrial maturation, and hence we may never be able to give them a fresh embryo transfer and have to go for a freeze-all intervention. The clinical practice questions here that we already have is, what are the indications of the use of gonadotrophins, the timing, comparative efficacy of all these treatments, at the RCTs in all these variables that we have is very low in terms of PCOS. So the moment we start, we want to start a patient for ovarian COH, controlled ovarian hyperstimulation for IVF. The first thing that we might have to decide is, am I supposed to go for an agonist or an antagonist protocol? So based on what can we decide on this? First, to decide on the type of downregulation we have, the statistics favors antagonistic protocol in few areas. That is, number one, when we use antagonist protocol for downregulation, the reduction in the amount of gonadotrophin used is quite less. We have a decreased quantity of gonadotrophins to be used as compared to an agonist protocol. We have the number of days of gonadotrophin use is also reduced, and there is definitely a decrease in the OHSS rates. However, there was no statistically significant difference found in terms of clinical pregnancy rates or miscarriage rates or the number of oocytes or cancellation rates or multiple pregnancy rates, whether you use agonist or antagonist protocol. So the advantage of using antagonist protocol is for A, cost cutting, which is the less use of gonadotrophins, so decreased amount, that is decreased dosage and the decreased days of gonadotrophins, and 2 is to reduce the complication, which is the OHSS. So since we are also worried about the cost and definitely we don't want an OHSS, antagonist seems to score over agonist when it comes to PCOS patients. And another advantage of antagonist protocol when we go for PCOS, when we have an antagonist downregulation, we can trigger using an agonist. When we trigger using an agonist, the OHSS rates are almost nil. We cannot trigger an agonist protocol with an agonist. We have to go for HCG for trigger in that particular protocol. And the next question that stands in front of us, am I supposed to use a urinary or a recombinant FSH, or am I supposed to use a HMG? So I'm just going to give you a few more studies on what has been said. There was one small study which said that there is a moderate risk of bias when compared to FR, that is rec FSH, recombinant FSH, with HMG, but found that the recombinant FSH was slightly better for the duration of ovulation stimulation required. That is, the number of days of stimulation required was less. The number of oocytes retrieved was more, but then HMG was better for the maximum serum estradiol levels. That means they had less estradiol levels, and hence the OHSS was slightly less. What did the Cochrane say about this? The Cochrane had looked into about 42 trials with a total over 9,600 couples, which compared rec FSH as against the urinary preparations. Rec FSH, irrespective of the downregulation protocol, did not result in a statistically significant difference in live birth rate or the OHSS rate. The clinical choice, and hence the clinical choice of gonadotrophins, should depend on the availability of the gonadotrophins, the convenience of the dosage, the cost, and that further research is definitely necessary in comparing whether you need to use urinary or recombinant or HMG. And the Cochrane also said in 2019 that there is little or no difference in birth in multiple pregnancy or clinical pregnancy or miscarriage rates between urinary derived gonadotrophins and recombinant recombinant FSH as well in PCOS. For HMG or highly purified HMG, whereas when compared to a urinary FSH, there was also uncertain, and whether they didn't find basically any difference between the two. So I guess either any of that can be used to go in for a stimulation, but then what we need to have basically is controlled ovarian stimulation, not uncontrolled where you have 80 eggs and 70 eggs. We need to go for controlled ovarian stimulation. That is the key in terms of stimulation for women with PCOS. It's quite difficult. We might go for a long period of time, but that's what matters, because we really don't want them to have 80 eggs and 70 eggs. Why? We would be coming to easy in a short period of time. And once we have done the ovarian stimulation, we want to trigger. Now we want to know whether should I use HCG or agonist trigger. In a fresh autologous cycle, GnRH agonist trigger is associated with less or no OHSS, but it is also associated with lower ongoing pregnancy rate and a very high miscarriage rate. And so where can we use agonist trigger? Is best used only in donor recipient cycles, or when we have already decided that all the embryos that we make in that cycle will be frozen and have only no fresh transfer and have only frozen embryo transfers. So when that pre-decision is taken, we can go for GnRH agonist trigger. So coming to egg numbers. So we all have gone through this paper by Sunkara, Sheshkamal Sunkara in 2011, which was a large study of about 400,000 cycles, that's 4 lakh cycles from a database. And she arrived that the best chance of a live birth was seen when 15 oocytes were collected, with an odds of decline of the live birth rate after every egg that is taken after the 15th egg. However, the concept seems to be changing right now, and let us look at the concepts. The SART, which is the American database, also studied the association between total number of oocytes available in pregnancy outcome, but in a first fresh IVF cycle with only a single blastocyst transfer, and found that the chance of pregnancy and live birth rate increased significantly with every additional fertilized oocyte up to 9, but there was a decline after that. Now, why are we worried about egg numbers? Basically because PCOS are hyper responders and you expect to have lots of eggs. So we need to know, suppose you have 80 eggs, even if you have 80 eggs, the pregnancy rate will be low. Whereas somebody around 20 eggs has a high chance of pregnancy. Now we are seem to have some making sense to the observation that we have been having. The odds of a clinical pregnancy, according to the SART database study, which I just mentioned, the odds of a clinical pregnancy and of a live birth rate were 8% higher for each additional oocyte up to 9 fertilized oocyte, and declined by 9% for every additional oocyte after 9. But these were autologous transfer of a single blastocyst and less than 38 years. However, right now, this is for a fresh transfer. We are not, if the patient or we as the provider, we are not looking to have a fresh transfer and we prefer only frozen embryo transfer from the onset, we can prioritize maximum egg yield as compared to our objective of having a fresh embryo transfer. Whereas there was a European study in 2018 which was based on a retrospective analysis of around 14,000 patients. It was a multi-center study evaluating the impact of ovarian response or on cumulative live birth rate. It found that the cumulative outcomes continue to improve with an ever increasing number of eggs available and reaching to about even 70% when more than 25 eggs were retrieved. However, no plateau was observed, although the cumulative rate did fall when initial cycles collected more than 27 oocytes. So around 25 could be our cutoff to know that it's an optimal number. A new registry study from the Australia and New Zealand database further suggests that it is a female age which dictates the optimal number of eggs needed for IVF cycles, giving the maximum cumulative live birth rate. The cumulative live birth rate appears to be maximized when around 25 oocytes were retrieved from women between age 18 and 35, more than 30 between 36 and 44, because the aneuploidy rate in the eggs, and around 9 with women 45 and older, because at that age even to get 9 is going to be very difficult. So what is the strategy to have when it comes to PCOS in IVF? The one, prioritize having more eggs. Please do not concentrate on having a fresh embryo transfer. That is for poor responders and normal responders. Fresh transfer is not the objective for PCOS patient. The objective is to maximize egg yield. It is associated with OHSS. The higher the egg yield, higher will be the chance of OHSS, and hence please go for elective freezing of all embryos for FET in subsequent cycles, which means please go ahead and you're free to give GnRH agonist as the trigger, which means the incidence of OHSS will be very low. And freeze all is the strategy which is perfect for hyperresponders, which also increases the cumulative pregnancy rates. So we have had 25 eggs, and how do I prepare the IVF lab for this? The devil in the IVF lab is in the details, or the success in the IVF lab is always in the details. What should I do? The moment there is, for every patient we do this, that is, the moment there is a patient who is coming for pickup, we always get the case sheet and see, follicular monitoring sheet and see how many follicles are there and how many expected eggs am I supposed to have, because I have to prepare adequate dishes for the amount of eggs. For example, every follicle which is above the size of 12 or 13 mm, I expect that will give me a mature egg. So I have to count the number of follicles above 13, and then I say I'm expected to get so many number of eggs, and hence I have to prepare dishes accordingly. Now, why I'm not supposed to just give only one small dish and put all the eggs together? Because there is a ratio of ratio of how much media, culture media, each embryo will require. Each embryo must be cultured in a minimum of 15 microliters. So in that case, if I have a drop of 100 microliters, I can put maybe 5 or 6 embryos into it. Maybe I can even accommodate the 7th. But then beyond that, it will increase the density of the embryos in that particular drop, which means there will be lots of reactive oxygen species and the excreta and metabolic excreta in the media, which will reduce the culture system, the optimization of the culture system for that particular patient, and hence there will be higher fragmentation rates, poor quality embryos, and definitely it will cause reduction in the pregnancy rates. And the most important thing, please recheck on the male partner to confirm sperm count. Suppose I see the follicular sheet and then I know that I'm going to have at least 25 to 30 eggs. But then if I don't check the male partner, he has got less than 1 million or occasional sperms. However, they have forgotten to freeze any backups. In that case, I'm going to be landing up with 30 eggs on my hand with such low counts of sperms that I may not find the number of sperms that is required to do the ICSI. So whenever there is a high oocyte yield which is coming through the IVF lab, we always have to make sure that we have adequate backup or the adequate information on how to have the sperms from the male partner. And the moment we know that a PCOS patient is coming with a high oocyte yield, we have to be already available and ready with the adequate consumables for vitrification. So the moment a PCOS patient comes, we have to be ready with the consumables for the dishes, the male partner, and with the consequent vitrification as well. So all these things is like must be done for anybody who is expected to give us a high oocyte yield. Now, what is coming through for PCOS? Everybody has got this question in mind. Will in vitro maturation be the key or the answer to PCOS? Unfortunately, though IVM has been happening for quite some time, it has not taken up very well because the results have not been very good. The pregnancy rates are reduced, the miscarriage rates are high, and hence we have not been able to implement that clinically for all patients with confidence, and hence we are yet to see. I wouldn't do it for the patient. So even people who have tried have not been doing it now. So this probably is not the time to implement that clinically. We will still have to wait for more information, more clarity on whether this can be done. In the sense, it cannot be done as of now. We need to have improvements in terms of culture media and everything for this to be made clinically available for our patients. This is one paper which I would recommend that all people can read because it gives it's very beautifully, it gives a gist of every clinical question that we do have in mind in regard to PCOS. It is freely available on the internet, and definitely I would recommend that we go ahead and go through it because it A, addresses the clinical question, B, it gives the answer through the Cochrane review or the systematic reviews. It also gives us a clinical perspective of the answer that is given. And thank you very much for the patient hearing, and I'd be very happy to take any questions.
Thank you, ma'am. Thank you very much. That was an excellent presentation, useful information, of course. And we would be waiting for the questions in the chat box. Doctors will post their questions in chat box. So if any questions are there, I will raise those too. Ma'am, any particular strategies as far as the adolescent PCOS women are concerned?
Adolescent PCOS, say, as of now, I would say that adolescent PCOS, the mainstay seems to be the COCs, but of late, what we've been doing is instead of giving them contraceptive pills, we prefer to put them on myoinositol for quite a long period of time, so that they do seem to, and of course, the first line seems to be the lifestyle modification. So after that, we tend to put them on myoinositol for a long period of time instead of hormonal supplements.
Right. Okay.
I guess there was no questions.
Ma'am, as far as lifestyle modifications are concerned, I mean, how well the results can be seen in PCOS women?
The lifestyle modification, once done properly, it becomes a lifestyle for us. That's the way we would live. And I would tell you the results are phenomenal. Phenomenal. If our patients stick to it, the results are phenomenal. That's one thing that will definitely help the patients um, in all ways. I think Priya Selvaraj has asked a question. Hi, Priya. Thank you very much for your words of encouragement. So your questions, PCOS with do 15 arc? Hello? 15 AFC. Do well with short protocol with dual or single trigger using recombinant HCG or agonist, reduced on almost or nil OHSs. That's true. Yeah. So we can go with the recombinant or, yeah, 15 is a good number. Yeah, 15 is a good number. Anything more than that is different. What kind of PCOS do we anticipate poor egg quality? In terms of poor egg quality, what we expect in PCOS is when they have extremely high numbers of egg, that is more than 35, 40, 45. I had one patient with 80 eggs, and unfortunately, it was like a honeycomb ovary, and she gave me only 80 eggs. And we had like a blastocyst stored, but unfortunately, she never became pregnant. So I guess it is a number which is a key, but the abnormality in the case is not at such an abnormality like how we would see in terms of endometriosis or anything. Here we would see a large number of immature eggs, and that's a key thing because immaturity is the key in PCOS. Not only nuclear immaturity, cytoplasmic immaturity as well, and that is what we have to keep it in mind.
Priya, can you hear me?
Yes, I can hear you now.
Thank you. That was a wonderful explanation. Very nice, concise lecture covering all points. So that's what I'm thinking, because even we had a similar experience. And I always tell the patients, you will produce a lot of eggs, but don't be happy with that because we have a big range of quality. We'll be happy with only some 10 to 15% of the eggs that you give us. And very rightly said that, the more you get, we cannot be happy because the rates of immature oocytes are higher.
Yep.
Very well put that, you have cytoplasmic and immaturity, and also the appearances, morphological appearances are not too great. Well put. So that's what I just wanted to ask that.
Because see, around 25 to 30, we are happy about having that number of eggs. And anything beyond that, we know that it is not great. It is not just the nuclear maturity that we would see immaturity. We know that just looking at the cumulus, they'll be so transparent to look at. So you have to give them lots of hours of to cope up with the rest of it for cytoplasmic maturity as well. So yeah, that's a key drawback in PCOS patients.
Yeah. And that's why, so when we have to reduce the OHS rate, so I've switched over to short protocol for these people where we anticipate, like you said, okay, people who knows may have had laparoscopic ovarian drilling also outside. Then so we don't want an excess of weight. So I tell them, please anticipate quality more than quantity.
Absolutely.
protocol, dual trigger works well. Sometimes we take a risk with adding dual trigger, that is HCG.
HCG and agonist, yeah.
We used to use urinary HCG, but then that triggers of OHSs more.
Yeah.
So one works well. So that's what I thought I'll just share.
Yeah,
okay.
true.
Very much. Very nice presentation. Enjoyed.
Thank you.
Congratulations.
Thank you.
Thanks to Shield as well.
And the one important thing to have pose in the luteal phase to avoid OHSS is the ones we do the pickup. You can start the patient on antagonist on a daily once a day or even twice a day if the number of eggs is just very high or the estradiol is very high. That completely suppresses the OHSS. Nowadays we have given off using any albumin or mannitol or whatever. None of that is used right now. Any protein supplement, astamin food, all the thing we used to use in bulk quantities. But now none of that is used. Just give them antagonist on a daily basis for the next 4 to 5 days, and no OHSs. It's completely negates the OHSs.
Cabergoline. And then
Yeah, yeah. That's always been there, but then now I think antag has taken the role. You remember, Priya, with the long agonist protocol, we used to be like clinging on to the IP with all those patients after hyper responders with agonist protocols. Life is so good with antagonist protocols.
Very bad. And so with this, we sometimes continue in the luteal phase, like you rightly said, and most of them go for FET. That's another nice thing that is happening. Just shifting to a frozen embryo transfer.
Absolutely, yeah.
Good discussion.
Because of the vitrification quality is very good now. We are very sure of our embryo freezing. We offer all our patients who are hyper responders to go only for frozen embryo transfers. Why take the risk of fresh embryo transfer?
Absolutely. Somebody has asked a question for you, and maybe that's something they've asked.
Can you suggest food items good for PCOS? I think Priya Selvaraj is the best person to answer, but however, I will try here. Basically, I think what we need to do is combine both food and exercise. Exercise is the key in PCOS because the basis here is insulin resistance. It is not just any other factor of high calorie or anything. We need to work on the peripheral insulin receptors on the muscles, and that is the key to reducing the hyperinsulinism and the insulin resistance in PCOS. So it has been shown in publications that it is the exercise that is the key. Even if they don't have a low calorie diet, if there is good amount of exercise, the hyperinsulinemia and the associated hyperandrogenism does come down. But however, what food to eat? Definitely, there must be reduction in the fatty food. There must be reduction in the high calorific content food. So they should go for higher proteins, more fruits and vegetables rather than they should have less calorie, less fatty diet.
Yes, ma'am. Thank you very much. Let me see if there are any more questions. Ma'am, I don't see any more questions, but yes, discussion with Dr. Priya Selvaraj was very useful, especially to avoid the strategy of OHS. And thank you very much, ma'am, for your excellent talk. Balaji sir, do you want to say something? Thank you very much. Yes, ma'am. Many thanks from Shield Healthcare. Thank you. Thanks a ton.
Thank you very much, doctor.
Thank you very much. Thank you.
Thank you. Thanks so much.
Thank you, ma'am. Bye-bye.